Hello, friends. Let's take a quick look into Harrison-based Alzheimer's disease. So, Alzheimer's is most common cause of dementia. 60 to 70% of cases of all dementia is Alzheimer's only. Major genetic factor causative for the disease is ApoE4. Remember, it is E4, not E2. Microscopically, what you will see, amyloid plaques you will see, neurofibrillary tangles, and amyloid angiopathy. As this as in this photo, you can see the big arrows. These are neurofibrillary tangles, and the small arrows are neuritic plaques. Then, can you see this PET image? So, this is PET image showing PIBSUVR, which shows amyloid uptake. FTPSUVR shows you neurofibrillary tangles, and FDGSUVR shows you glucose uptake. So as you can see, yellow and red shows you higher activity and blue and green shows you lower activity. Okay, now what are the clinical features for Alzheimer's disease? The earliest feature is memory loss, anosognosia, and then patient will have aphasia, anomia. Patient will have difficulty in finding words. He will have decreased verbal fluency. Then he will have executive dysfunction. He will have problem in planning and coordination, visuospatial dysfunction. Then psychiatric, he will have apathy, depression, anxiety, and the patient will be belligerent. He will be always ready to fight. Apraxia, he will have problems in dressing, using tools, and patient will have agnosia. It can be prosopagnosia, that is difficulty in recognizing faces. Average survival in Alzheimer's disease is 8 to 10 years. Why? See, patient will be lying in bed. He can develop secondary infections. He can develop pulmonary embolism secondary to DVT, which can be cause of death. Then this photo is also quoted by Harrison. So this is amyloid precursor protein, as you can see. So we have beta secretase product and alpha secretase product. As you can see, beta secretase product give rise to A beta 42 and A beta 40, in which A beta 42 is toxic and A beta 40 is non-toxic, and alpha secretase product give rise to P3, which is non-toxic. So we in our therapy we have to remember, we have to enhance alpha secretase because that is giving non-toxic products, and we have to inhibit beta secretase and gamma secretase so that we will have less A beta 42. Then what will be the treatment for Alzheimer's disease? So we have three drugs, that is DRG, famous mnemonic DRG, donepezil. Target dose will be 10 mg. You will start initially with the lower dose, and over 4 to 6 weeks you will increase the dose to 10 mg. Rivastigmine is 6 mg BD and galantamine is 24 mg. What these all drugs do? They are cholinesterase inhibitor. So they will increase cerebral acetylcholine and will helpful in the disease. Then we have memantine, which is NMDA receptor antagonist. Okay, and we have new update, that is a monoclonal antibody which is called aducanumab. So it will be very helpful in reduction in A beta plaques. So but FDA approves it only for minimal cognitive impairment. See, if patient has early Alzheimer's, then you try these DRG drugs, but if he is not improving or he is going into moderate to severe Alzheimer's, then from DRG you add memantine. But this monoclonal antibody, it is not advisable by FDA for moderate to severe disease, but you can use it in minimal cognitive impairment, that is a stage before Alzheimer's disease proper. So how to give this antibody now? You can give it by IV route. Every 4 weeks you can give 1 milligram per kg you start with, and you can give up to 10 milligram per kg over 7 infusions. So what is side effect for this monoclonal antibody aducanumab? That is ARIA, amyloid related imaging abnormality, which can be manifested with headache, altered mental status, or visual abnormalities. So you have to do, while giving this antibody, you have to do MRI surveillance or patients in which MRI is contraindicated. For example, patients with pacemakers which are MRI incompatible, you cannot give this monoclonal antibody, that is aducanumab. Then what are differentials for Alzheimer's or dementia? That is chronic alcoholism. It can lead to thiamine deficiency, which can result in dementia. Then B12 deficiency, if patient has loss of vibration, proprioception, loss of joint sense, position sense, positive Romberg, it could be vitamin B12 deficiency and not Alzheimer's. Then if patient has rapid onset dementia along with myoclonus, then it is your prions disease. Then patient can have Parkinson's also, but in Alzheimer's these tremors, resting tremors will be absent. Additional therapy. See, patient with Alzheimer's, he will be having some sort of dementia also, depression also. So for depression, we can give SSRIs because they have very less anticholinergic effects. In SSRI, we have escitalopram. That is 5 to 10 mg you can give daily. Antipsychotics also, patient will be having anxiety. So you can use atypical antipsychotics like olanzapine, quetiapine and risperidone. Two other monoclonal antibody mentioned by Harrison is lecanemab and donanemab. And what will MRI show in Alzheimer's disease? There will be medial temporal lobe atrophy, especially hippocampus and entorhinal cortex. Then there will be temporoparietal cortical atrophy. That's all for today. Thank you.